Welcome, everyone. This is the second installation of the Prostate Cafe, and I'd like to thank you for coming. In the background there, you'll see some of our propaganda, there's papers, leaflets on different things. One is the latest, which is a Journey Express, and that's something that we put out. It's a newsletter to our patients. There's a lot of information therein, and I know it's been mailed to thousands of men, but it can also be found online. There's some other articles there, including something I published, or let me say I wrote about 4 weeks ago, called Good Radiation. And there's some interesting information within that. There's also a paper there on prostate biopsies. And while today I'm looking to post any question you possibly have on prostate cancer, I thought that if we do have time, and if there's no other questions, then we'll go into prostate biopsies, just because it's a very interesting topic right now in urology and oncology as well. I'd also like to thank Provenge. It's the Dendrion company that sponsored today's breakfast. They're really interesting. We've been working with them for about 14 months now. And in oncology today, there's a move afoot, which is basically looking more and more at immunotherapies rather than the old days, which were cytotoxic chemotherapies. And I predict, there'll come a time in the future when there will no longer be cytotoxic chemotherapies, which, we all know targets your entire body. So it's kind of like poisoning of your body, but it happens to poison the cancers better because cancers are growing faster. But we're looking more and more into targeted therapies. And with prostate cancer, immunotherapies are not working out as well as they are in other solid tumors, but they are moving, and we're getting into other agents called PARP inhibitors, which are selective and they target specific cancers. But what we do now is look at someone's molecular profile, and that could be taken by a patient's biopsy, or now more and more we're doing it just with the blood sample. It's called a liquid biopsy, and if it shows certain mutations, then that may point a patient in a direction other than chemotherapy, but rather immunotherapy. And of course, there's a big role for hormonal therapy in prostate cancer. And for a long time, no one really knew why hormones work so well in patients having prostate cancer. But now, with the understanding that immunotherapy is working for so many people, we're now identifying that hormones are a powerful stimulant of the immune system. And I think it's, contrary to what people think, but it does. It's a powerful stimulant. Now, it also carries its side effects over time, and we try to minimize that exposure to hormones, but they really do evoke a powerful immune response. And more we're using some additional second-line agents, which are available now. There's actually 5 of them, and they're very interesting in terms of evoking that immune potential. Similarly, radiation also upregulates the immune system. And again, back there, I have a paper on that. It's called Good Radiation. Is there such a thing? And yeah, there is, and it's very interesting. And what we've identified now is that when a person gets simultaneous radiation and hormones, with each having the probability of driving up the immune system, but you give them together, and it's a big bang. You actually evoke a huge immune spike, which can then travel throughout the body and kill prostate cancers. But the Provenge by the Dendrion company, that's very interesting, since what they do and what we do here is we extract blood from you, okay, and that blood is then sent out to a private laboratory where antibodies are created against your tumor. So it's very specific. It's a tailored type of immunotherapy, and has great results with overall survival and life expectancies and so on and so forth. So that's about it. So again, if there is no other questions, we'll go to prostate biopsies, but hopefully we can fill this conference with many questions. Yes, sir.
I have stage 4 reoccurring prostate cancer. I'm on the hormone treatment or and Erledia.
Okay.
It has lowered the testosterone down to practically zero.
Right.
Now, how long do you think I could be on that?
It depends. When you say recurrence, where the prostate itself or elsewhere in the body?
Well, it's early stage 4 in the spread to the, what was it?
I don't know. The lymph system.
Maybe a
Lymph
lymph node.
Okay. Because sometimes here, and there are many places in the country, we don't really think of lymphatic spread as being stage 4 disease. We think it's a very treatable disease. It depends, which lymphatics are involved. Now, some men, it's a very extensive amount of lymph node disease, and where you really can't treat it. But if it's more regional, if it's in the abdomen, if it's in the pelvis, or even in the thorax and the mediastinum right around here, we've had really good results treating patients with both radiation and the hormones. Because again, we're always looking to take advantage of a big immune spike. And so that's interesting, as I was saying, hormones upregulates the immune system, so does radiation. And if you give them simultaneously, 1 + 1 doesn't equal 2, it equals.
If I had the seeds before though, can you still use radiation?
You can. There's also in the leaflets we put out there's data on our most recent publication in 2024, where we do retreat patients having recurrent prostate cancer after having had radiation.
Yeah,
so it's re-irradiation.
I did one of the, what's that test where they discovered it?
PSMA PET scan.
Yeah.
Yeah, so PSMA PET scan is now the most common imaging test for prostate cancer. It's a good test. It's not the best. We were using a nanoparticle test for a long time right here between 2008 and 2018. That was really something because we could pick up disease in its infancy, millimeter, sometimes less. And again, we published extensively on that. But that gave way, and the best we have right now is a PSMA PET scan. And they're very good. But I do know we were working with the nanoparticles in around 2014-15, the University of Michigan, Ann Arbor. We were working with them on the PSMA PET scan. I had quite a number of people get both. And it was true that the nanoparticles were better. But again, PSMA PET scan is what we have, and it's a good test.
So how long do you think the hormone treatment would last before it's ineffective?
It depends. So everybody's different. It could be anywhere from 18 months to, we have patients who we've had on second-line agents, for a decade, since they came out. The first.
You do the interval dosing where you.
The intermittent dosing, yes.
Yeah.
Yeah, I think that's an advantage because continuous, dosing is beats your body up, not to mention there's increasing data now which suggests that even in a person who has been on hormones for a long time, and what ends up happening is the cancer does become resistant. And despite the hormones, your PSA starts rising again. And that is typically inevitable, but it could take varying periods of time, as I've told you, years to decades. But that's it. So what we'd like to do is not continue with the hormones, because our thinking is that it may drive cancers to become resistant faster. Plus, there's increasing data suggesting that going off the hormones and allowing your body's testosterone to come back actually retrains the prostate cancer cells that were resistant, that were not responding, to respond again. There's a couple trials. One is called the Transformer trial, and another one's called the Batman trial. Unusual names, but they're interesting. And what they actually do is in patients who have prostate cancer and resistance, where they've been on hormones and they're resistant to the hormones now, and their PSAs are still rising, is to actually subject them to powerful doses of testosterone, and doing that for 3 to 4 months, and then after that, putting them back on the hormones, and guess what? The hormones are now working again. So it's very interesting. So that kind of also lets us know that intermittent hormonal therapy, where you're not on it all the time, but you're on and off of it, is beneficial, because that's in essence what's happening. You know, especially with Orgovix, you know, where you can have a pretty quick rebound of your testosterone once you stop. So it's all interesting, but you know, the problem is men have to realize that when we're doing that, we're trying to transport an aggressive disease to become a chronic disease. And that's a big, that's a win, you know, because we can turn prostate cancer into a chronic disease, like, you know, every other disease in our bodies primarily have, you know, a problem with hypertension, cholesterol, all those things are chronic diseases. With prostate cancer, we can retrain the prostate to be chronic, where we can control it one time
What
after
would
the
be
next.
the time on the intervals?
It
How many
depends.
time off and on?
What I typically do in intermittent is first we try to drive the PSA down to negligible, undetectable ranges, and then that may take 6 months to a year, and that's the first stand of hormones. Then you go off of them, and then we watch the PSA and we pick a number. So the number that I usually pick is, well, what was the number that you started on the hormones with? Was it 4? Was it 10? Was it 100? Whatever that number is. I don't like 100, but some higher value. We wait for it to get there and then resume the hormone. So it's variable also. You know, some men are off hormones for years before that happens.
Good.
And there's some other ways that we try to kind of beat down the prostate cancer without beating you up. So while you're off the hormones, we have other medicines that we use, which are not hormones at all, but they have anti-prostate cancer effects. And so it could keep you off the hormones longer. So, and then again, that's an important thing to have.
Thank you.
Yes, sir.
There seems to be a lot of ways to identify that you have prostate cancer, but I haven't found a good one saying you're cured, you don't have it any longer, other than they monitor PSA. Is there any other way that you can tell that you no longer have it, or you always have it?
Well, it depends. You know, again, sometimes we use something called, we follow a protocol called the oligometastatic disease protocol. What it means is even a patient who has advanced disease, if you treat them aggressively, you can take advantage of what I've been talking about, evoking that immune response and hoping that the immune system kind of comes to the rescue and kills the prostate cancer entirely. Now, that we achieve, we do achieve that. And, you know, we have many patients who achieve that. Others, again, that may not be an achievable goal, but we can make their disease chronic. But I mean, if you want a staging study, it would be the PSMA PET scan, you know, is the best that we have here in the States. You know, if you're traveling to Europe, there's a place in the Netherlands, University of Nijmegen in the Netherlands, that does the nanoparticles, and we were working with them not that long ago. They do a wonderful job, and it's still available there.
They put me on Zytiga
Uh-huh.
and 1,000 milligrams every day.
Right.
Do I have to continue that forever, or is there?
It depends. Is your PSA dropping? Is it gone to low
Well, I'll
values?
stop 1.3 now.
Dot
But that
1.3.
was due to all the hormone shots and everything else they gave me.
Okay, so yeah, that could be low enough. Says I usually use 0.2. Once it gets down, you know, less than 0.2, then time to start rethinking whether or not to continue the hormones or not.
Yeah, because they told me 2 years, so
2 years being on it.
that's how long I should stay on it.
Yeah. So yeah, I try not to make the, you know, numbers like that, but rather, I mean, I may tell you, well, it's going to be a year or two, something like that. But if your PSA drives down really quickly, you know, to a very low value, then, you know, we could stop it sooner.
Yeah.
You know, so everybody's different with respect to that. Every cancer is different. Yes, sir.
When I first talked to you, I still needed a biopsy.
Okay.
And you called me back, told me to get one at my urologist before I come down because of insurance issues having them done here. What is the difference between doing the biopsies at my home and getting them here through you?
When we do biopsies, it's different, okay? And I'm not saying no one else in the country does. There's some places in the country that do, but generally speaking, when biopsies are done, by urologists elsewhere, they're going to go through the rectum. So they're called transrectal ultrasound guided biopsies. Not always the case, but do you know if yours were through the rectum?
Yeah.
Yeah, that's just the most common. I would say 99%, maybe 99.9 are doing transrectal. That's just the way most urologists have been trained in doing it. So let me first talk about that, and I can tell you that let me say the downsides of that. Okay, and I know you've already had it, so you know it's done. It's water under the bridge. But why we don't like it is because when you do pierce the rectum, it can be painful. Now, in most cases, you're anesthetized, so it's not that bad. But even afterwards, you can have more pain because there's a lot of rectal pain sensors. We all know that. You know, the rectum is filled with sensors. That's why when you got to go, you have to have a bowel movement, you really got to go because it's pressing on those sensors. So if you hit something hard, like a biopsy, it can be painful. Secondarily, because you're going through the rectum, you're potentially introducing bacteria from the rectum into your bloodstream. First into the urinary tract, but also into the bloodstream because the rectal area has a lot of vascular supply, which heads right off into the general circulation. 2% of men who have prostate biopsies end up in the ICU, with bloodborne sepsis, where their whole body's infected. It can be a very dangerous situation. That's another reason why we don't do it. Also, with transrectal biopsies, there is a potential of spreading cancer, into the bloodstream. Now, hopefully, it's just a small amount of blood, and it's not going to amount to much. But there's a small percentage of men it has been identified to actually disperse cancer cells. Okay. Also, when you're doing transrectal ultrasound guided biopsies, it's not so directed. Now, there has been a move afoot using MRI as a guide, but it's a static image. So what you do is you get an MRI, and the MRI is done, and then it's kind of looked at from the standpoint of, okay, here's my prostate, but I'm doing it with an ultrasound, trying to find on the ultrasound where it was on the MRI. It's called a fusion biopsy, but it's actually not so precise. So those are the reasons, and so typically when you see a prostate biopsy per rectum, it's going to be A through L, which is 12 biopsies. And they're trying to get like the different quadrants, upper, which is the base, and the mid, and then the apex, which is the bottom, on each side. But anyhow, in contrast, and I did them that way a long time ago as well, but I would say for the last 20 years, I have not been. And instead, we do what's called transperineal prostatic biopsies. So transperineally, the way you do it is you're no longer going through the rectum. So with a probe in the rectum, an ultrasound probe, you're viewing the prostate live. And we use these special ultrasounds called three-dimensional color flow power Doppler ultrasounds, very exact. And they tell us exactly where the tumors are. And the perineum is the area between the scrotum and the anus. And it's almost devoid of pain receptors. And what I like to do is even during and after the biopsy, I do something called a pudendal block, which is just putting a little lidocaine along the nerves, and it just numbs it. And so there's not a lot of pain to begin with, and afterwards there shouldn't be a lot of pain. Also, there's no potential risk for skirting bacteria through the body. Now, there have been cases of that, but it's very, very, very rare. It's not like transrectal ultrasound guided biopsies. Also, we're able to take the imaging of MRI and transport it into our ultrasound systems, and then use both MRI guidance and 3D color Doppler ultrasound. And then every single snip we take is through a template. The template has these tiny little apertures in it, which tell you, it'll say A1, which is a certain location on the template, which means a place in your prostate. So at the end of our biopsies, there's no mystery. It's not like, well, it just came from the upper left. No, we know exactly where in the upper left it came from. So it's just more precise. Okay, so these are the reasons why we do it that way. Yes,
Is
sir.
that template similar to your seating template?
It is very much so, and that again works in our favor because If we know exactly where the biopsies were taken, then we also know where to hyper the dose when doing the brachytherapy. Because yes, we use the exact same template. But here we're more into more specific targeting, even with the radiation that we deliver here, which follows an acronym called DART, which is Dynamic Adaptive Radiation Therapy. It's pinpoint precise, and with it we can also identify exactly where the cancers are from our biopsies or from our 3D Doppler ultrasound, which I'm sure you have. I know you have. And it identifies exactly where the cancers are, and then we zero in on that with the DART as well. So we hyperdose with the DART, we dose escalate with the brachytherapy so that every area of the prostate is getting a different dose.
One more question, I will stop.
It's all right.
I noticed a lot of the hospitals are using the varying machines,
The variant?
manufactured.
Mhm.
And I'm assuming these machines, they look alike, they aren't the same.
That's correct.
That's all.
Yeah, so Varian has been a tried and true company. It's probably the most known, radiation accelerators. They're these giant machines that we have here, and we also use Varian. They're considered the Rolls-Royce of radiation. Okay, and there are other companies that have tried historically to compete with Varian, but they can't seem to do it. But yeah, every machine is not the same. And what we do here is we take the machines and then through the years, we keep adding to it. So we have a lot of 3D and 4D imaging, which goes with the machines. So there's your basic machine, and then there's your machine that's got, a lot of extras on it. And that's what we do. And that's what we've done here so that we can deliver radiation with pinpoint accuracy called DART, which stands for Dynamic Adaptive Radiation Therapy, which means we're moving with the targets in real time. So there's no opportunity for us to hit bad, other areas, normal areas, where we can maximally preserve, normal structures, because we're going way out of our way to avoid that. You can only do that with dynamic imaging. There was a time, well, not that long ago, they were using MRI to do targeted imaging, and I had predicted it was not going to work out, and it didn't, and the company just went under. And the reason being is that, as you all know, if you've had an MRI, you have to stay really still, and because otherwise the image won't take, because it's so subject to motion, and so when you're getting treated with radiation, you're lying on a table, and those of you treating here, you have an alpha cradle below your knees, and you have a device to hold your arms up, but you're moving, and if you're try to track that motion with MRI dynamically, it's just not a good medium to do it. So here we're using other instruments like light speed helix CT scanners and 4D ultrasounds and a whole bunch of other technologies to track very quickly. Yes, sir.
Can you have a high PSA and still not have cancer? My PSA is at 12 right now.
Sure.
Is that a danger zone?
It doesn't have to be. So, as we all know, as you get older, prostate gland can get larger. Not always the case, but that's a common trend. And the bigger it gets, well, there's more prostate cells. Now, bear in mind that PSA is not only from cancer, it's also from the normal prostate cells. So if that's the case, then the more normal prostate cells you have, then the higher your PSA can be. And then what commonly goes along with that is a larger prostate bothers the bladder. It bothers the urethra. It impinges upon things, okay, because it's getting larger. And what that does is it sets off inflammation, okay, because your bladder's not working as it should. It's a little spastic because the prostate's pushing into it. So it imparts inflammation into the prostate. And now you're inflaming the normal prostate cells, which also make PSA, and the PSA gets even higher. So I've seen PSAs be really high, 50 to 100, in men, not because they have prostate cancer, because they have prostate inflammation, which we call prostatitis. And you could have acute prostatitis, which means it's quick, and then there's chronic prostatitis, which means it's kind of a problem. It's hard to manage. So yeah, you can have a PSA elevation. It's not always the number. It's also the rate of the rise. So we like to talk about doubling times. Doubling times meaning, okay, this is what it is now, what's it in 6 months? Did it go from 2 to 2.5, or did it go to 2 to 6? Because if it's going to 2 to 6, then the doubling time is rapid. So we look at that too. So for example, if your PSA is at 12, but the last time it was 6, and the time before that it was 2, well then yeah, it's probably prostate cancer. Because it's doing that stepwise, increase. Doesn't have to be, but typically is. On the other hand, many men with a large prostate, they get their PSAs and it's 8 or 10 or 12 or 6, or it's kind of all over the place. And it's just a matter of how inflamed is my prostate today when I'm getting my PSA tested. So, but again, you'd be served by having an MRI, to look at the prostate. And then, here we use our 3D Doppler ultrasounds to better delineate whether it's cancer or not. And then make a decision, is a biopsy necessary?
That's very good. Thank you.
Sure.
Is-
Yes, sir.
Is the brachytherapy, is that only viable if the cancer is in the prostate only? If it's spread to lymph nodes, then you have to
No.
use other.
No, actually, brachytherapy is a great treatment for men whose cancer has gone to lymphatics, lymph node dissemination. Understand that when all said and done, the prostate itself, wherever the cancer is in your body, the prostate itself is the engine for the rest of the cancer. The rest of the cancer follows what the prostate wants it to do. So it's, I often say it's a conductor of a big orchestra. And if you take the conductor out, then the rest of the orchestra just kind of falls apart. And that's the theory as to why we do treat the prostate. And it's very clear now that the higher the doses that you can achieve with the prostate proper, wherever the disease is, the higher the probability that you're going to create an effect where it's influenced. The rest of your body's cancer is influenced. It may just shut down entirely. So it's very, very important to put the fire out where the fire started, and that's the prostate. And that's the reason why here, men come back for follow-ups for a long time, and what we're always looking for is there any kindling of that prostate cancer in the prostate proper? Because that's something we've got to put out right away. It's very important. And and often when you see a patient who has recurrence elsewhere, in the lungs, in the bones, in the liver, wherever it may be, or lymphatics, and then you reevaluate the prostate, guess what? It's often back in the prostate. And it's the great conductor of a bad orchestra. Yes.
My husband's seeds were 16 years ago.
Mhm.
Could he have more seeds at this point?
Yes.
He could.
Yeah, again, there's a paper up there. It's entitled, it's an ASCO abstract that I presented at a meeting in January of this year. And it's up there and you can read about it. And we have a very good success rate with retreats, which, called re-irradiation.
Thank you.
Sure. Yes, sir.
Do you actually go into the lymph nodes or do you just treat the prostate and that? takes care of it?
No, yeah, good question. Generally speaking, I treat the lymph nodes. And the reason I do is because, I had a lot to do with development of brachytherapy, which is a local therapy. It's really precise. It's, it works exactly where you put it, but it's not gonna reach the lymph nodes. It's just far, far too precise. But when I was first doing brachytherapy a long time ago, I was making the claim that it was just the greatest thing, that you could ever do, because you could accomplish, basically what you could with the surgical scalpel and, not have incontinence and preserve sexual function and all that. But as time went on, I saw the failure rates, PSAs failing. And we came to realize an important fact about the prostate, and that is that the prostate does not have a capsule. And, I've been trying to educate the world about this for a long time, and I've made inroads. I would say 50% of urologists, oncologists, and radiologists know that, but the others don't. It's a very important aspect because most cancers of the prostate begin on the edge. We call it the periphery, the peripheral zone. But if you just think about that, if you're something on the edge, and so let's just say this is your prostate. The bottom is called the apex, and the top is the base. And so your bladder sits up here. But if you just think about it, if most prostate cancers begin in these areas here called the peripheral zone. But there's no capsule, so these can easily grow inwards, and that's what they do. But they can also, because there's no prostate capsule, they also do this very easily. Now, these are microscopic. You can't see them. You don't know they're there. The only instrument I would argue that we could actually see those would be a 3D colored Doppler ultrasound. And the reason we can is because these are not, don't leave an anatomic footprint, but because they're cancers, they carry a vascular supply, which is abnormal. We call it heightened neovascularity of prostate cancers, or cancers in general, but since our probe, our Doppler ultrasounds are looking specifically for vascular patterns, and we can see this area right here. The reason why that's so important is because, again, if you're talking about brachytherapy, let's say surgery, you're removing with surgery, you're basically bound by the boundaries of the prostate like this. So that if you've done that and you have the before and after picture, well, you still have cancer cells out there. That's the failure with prostate removal. That's the problem with prostate removal. But that's also the problem with brachytherapy, where you're just putting your little seeds into the prostate. Interestingly, a long time ago, and I published this in the early 2000s, I was discussing how you can put seeds even outside the prostate, and where they could be positioned even outside the prostate to potentially counter some of these extra prostatic tentacles, if you will. And the only way I found to do that, when I first started doing it, putting seeds out here, what I found is they would just kind of meander away. They'd walk around the area. So I started using isotopes, and when I looked at that, the isotopes themselves, we blew them up thousands of times, the seeds had these convex ends which allowed them to migrate. So I started putting in seeds that had convex. I actually had a lot to do with the development of this kind of seed. And what I developed is a tool, that kind of tiny tool which fits right in this area here. I spin it, and what happens is the seeds get locked in. Okay, however, what I also came to find was that was great, and I do that in almost every single case. But maybe these fronds are a little too long, or maybe these fronds are the first ones to go to these structures which are just outside the prostate called lymph nodes. And our pelvises are lymph node rich. There's hundreds of lymph nodes in the pelvis, and lymph nodes in our bodies to remove things that are not supposed to be there. So they're going to remove inflammation, they're going to remove infection, but they're also going to remove cancer because it's not supposed to be there. In many respects, we almost think it might be a good thing because it's kind of a stopgap so it kind of holds the cancer before the cancer widely spreads throughout the body. So based on, doing a lot of seeds alone and realizing that, yes, it was a great treatment, but it maybe wasn't how we could get into the 90+ percentile cure. Then I realized I would need some version of external beam radiation to also target these lymph nodes. And that's what we do today. That became very, very clear with the test I mentioned, the nanoparticle test, which is called Combidex, and we were working with Harvard and University of California, San Francisco, and that place in the Netherlands with that test. And we then got involved with another nanoparticle called Faraheen. We have a really large experience. There's some studies posted on the walls there, or some publications that I've had with nanoparticles. But what was really interesting about it is when we started doing nanoparticles, it was just a wake up, just how common lymph nodes were involved with prostate cancer. It seemed like everyone had, and we did really good studies where they were biopsied and removed, lymph nodes were removed that were determined to be positive. And yeah, they're almost always positive. It was a really indicative test, but it just let us know that prostate cancer just loves to go to lymph nodes, and even Gleason 6s are really commonly inflicting lymph nodes. And it all has to do with prostate not having capsule. Many organs our bodies do. When you talk about like kidneys have a big capsule on it called Giroder's fascia. Even your heart has a myocardium and a pericardium. So even the lungs have a space. Prostate has none. there aren't many organs in our bodies that have no capsule. And you can just Google that up and you'll see what I'm talking about. But anyhow, does that answer? Go ahead. Yes, sir.
So you radiate the lymph nodes as well, but not with seeds. You do
Not with seeds. We do it with the DART radiation that we have here.
each one of them.
No, well, the chain. So, here's the other thing. So what happens with lymph nodes is, let's just say this cancer goes to that lymph node. The way it spreads is by going to that lymph node, and that lymph node, and that lymph node. So it's an upward chain. It's like a ladder going up. So you can't just treat that lymph node, because if you just treat that lymph node, then you're not getting this tail right here. So typically we treat lymph nodes, we treat that lymph node and then also carry it up a little higher and treat that lymph node and carry it up a little higher and treat that lymph node. We just have a lot of experience here with treating lymph nodes. So, we realize the prostate or the pelvis has many lymph nodes. It's lymphatic rich and we need to treat them. And that's what we do. And, I've published, so to your question, or talking about lymph node treatment for men having more advanced disease, it makes a lot of sense to still use brachytherapy to put the fire out where the fire started, but then to treat the areas which are close to the prostate, because the other thing is that these tumors close to the prostate are also part and parcel with the prostate. So they're very similar. So I talked about the great influence of the prostate affecting lymph nodes up here and bones up there and lungs and liver, all those things. These close lymph nodes also have the same tissue of the prostate. So these are still part of that conductor of the orchestra, taking care of disease or hoping that it's going to fire up cancer distantly. So it's really important to put the fire out here, and that includes the lymph nodes around the prostate. And if we have imaging where those lymph nodes are even larger, then we'll treat, as high as we find them to be large. And we could accomplish that with DART with minimal side effects. And of course, in those situations where you're having, patients who have high risk of lymph node disease and more advanced lymph node disease, then hormones definitely comes into the picture as a necessary thing. Are there any other questions?
So you said you can do radiation and hormonal treatment.
Yeah, so whenever I do radiation for a patient having high-risk disease, high risk is defined as someone who has a high probability of cancer beyond the prostate and maybe we don't even know about the lymph nodes, but just an assumption that the cancer was aggressive and it has these legs, if you will, going outside the prostate. But we would like to use the hormones and the radiation in those situations because, again, we're looking to evoke that powerful immune response from your body, take care of the bigger picture, which is wherever the prostate may have gone to, cancer may have gone to. There's something called an abscopal effect, and you could also look into that. If you Google it, it's very interesting, and what it means is that, by eradicating the local area with radiation, and it seems to be unique to radiation, that it shuts down the feeders elsewhere to the body. So there's definitely, some crosstalk with the rest of your body, wherever the cancer may be, with the prostate itself, which is where it started. There's data about that with other cancers as well. Kidney cancers was actually the first one, which is also in the genitourinary system of the prostate. But kidney cancer was identified a long time ago that you take the kidney cancer out, the other cancers just wither. And that was the first site.
DART then? That's
We do, absolutely.
Is there some reason they have a certain number of days? Like they told me I have to do 28 radiation days. How do they come up with that figure that it's 28 days that I have to do?
It would be different. What's dictating the 28 is your insurance company, which is really bad. Yeah,
I
it's
thought
really,
there was some specific reason
that's a specific reason, unfortunately, but I think it's Aetna and Cigna, they'll only approve 28 sessions, which is crazy.
Oh.
Yeah. Yes, sir.
I'm midway through 36 treatments.
Yeah.
And I have low platelets and they're going lower. I haven't read your paper yet. I'm very interested in radiation, but negatives of radiation, is that one and how much
Yeah.
effect does that have?
That's not common. It's not common. Now, hormones, it's common. So hormones cause, we call it pancytopenia. What it means is all your blood elements of something we call CBC, complete blood count, they could all be suppressed and often platelets lead the way. But sometimes, if it's inexplicable, we have to look for other potential reasons that that's happening. But could be the hormones. Again, radiation, there's been lots of data about radiation potentially causing that problem, but as we've gotten more and more precise, it's just not so common. The areas of the hips and the pelvis in general does carry a lot of marrow, bone marrow, and yeah, it can be affected, but I don't see that very much. It's perfect. Not a lot. Yeah. Yes, sir.
Yeah, just sort of an aside thing. I have Aetna. And I got approved for proton radiation
Okay.
through them, which was 40.
Yes.
They disapproved me the first time. Then they had to go back and appeal
Sure.
through the CT exam. And I don't know what they said to me. But then
They did.
approve me for that.
Okay.
So.
Yeah, I know you have to appeal and appeal again sometimes and appeal again, because if you don't, they just paint everyone with a broad brush. No matter what the stage of cancer is, you're going to get 28 sessions.
Is proton better than the dark?
No, so protons are interesting. I worked with a doctor at Harvard, famous doctor on the Harvard cyclotron a long time ago. I'll try to explain it in a few minutes. So the brain and tumors in the brain are kind of the perfect site for protons. And the reason being is we did a cross section this way, the brain, the skull, calvarium would look something like this. And let's just say there's a brain tumor here, okay? So what you do with protons is it's a particle, and you say, okay, the proton's gonna come in like this. But the proton has a specific dose delivery, it's called a Bragg peak. And so what happens is you can determine with protons this depth, and let's just say it's 5 centimeters. Well, a proton comes in and it doesn't deliver any dose, 0, until it gets to 5 centimeters, and then it bursts with something called a Bragg peak right around the tumor. And we know that protons are typically can do that to about 6 to 8 millimeter size tumor. And then the beauty of it is electrons capture the protons, which are positive particles. And again, it meanders out, not touching anything. So this is a beautiful thing for protons because it's only treating that tiny little area. It's not touching any of this. However, when we start talking about the pelvis, where the prostate lives, then, okay, this would be the pelvis. And now you're talking about the prostate. It's larger than 6 to 8 millimeters. Okay, so it's typically to be something like this. What happens is there's many depths here. So there's, this might be 10 centimeters, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. It's all these different depths, but the proton can only deliver at a certain depth. So if you were to shoot in a proton and it was to meander like this, and you say, okay, it's going to drop a dose here, but it's only treated at one little area there. So how are you going to do it? Are you going to shoot 10,000 protons at the area so that they all disperse at a certain way? Remember, this is in 3D too. No, you can't do that. So what's done with protons is you say, okay, the incident proton's coming in. So let me put a big compensating filter here. What that filter does is it exploits the Bragg peak immediately. So what happens is the proton now comes in, the compensator filter exploits the proton so that the entire energy goes this way. And what that means is that the entire area is getting the high dose all the way through. So that the advantages that I just showed you with proton to the brain, in my mind, become disadvantages. So that what was driving protons, well, the protons were really going hard in the in the between 2010 and 2017, 18. And what's really driving it was the reimbursement. So they're reimbursing like $150,000 for protons. And what happened was, and many, even Medicare was paying that. But then the studies came out and they looked at what I would just say plain Jane IMRT. And the IMRT, which is something that's been around for about 20 years, maybe longer, beat out protons. So it actually had less GI and less GU, or if you really look at it, really dissect it, it's equal. Okay, so that the advantage of the protons were not greater than IMRT. So based on that, most insurance companies just drop protons like hot potato. And they said, we're not going to pay for that if another therapy, which is far less expensive, does the same thing. So that's been the problem. Not to mention in these areas of the pelvis, right about here sits your hips. And the thick hip bones typically get this enormous dose. And that's why it can result in fractures, osteoarthritis, necrosis down the line. Again, protons can be a wonderful treatment for other tumors. I recently guided a patient of mine to protons in Miami, which is closer to where he lives, just for his particular case called for protons. But generally speaking, I don't see a great advantage for those reasons. Any other questions? All right, we'll conclude our, oh, yes, sir.
I just want to thank you, doctor, for your intellect and there's so many variables. I'm an old CEO and so and have been solving problems my whole life, but it's so interrelated and we appreciate your experience, your curiosity, your caring and your research. It all comes together because, hey, you got to know what you're doing. We just feel
Thank
that
you.
way.
Appreciate it. I think our next meeting will be the 18th of May. May 17th. May 17th. It'll also be a Friday. We're typically going to have them on the third or fourth Friday. Yes.
So,
Mhm.
we just happen to be in town for a follow-up.
Okay.
And since
Yes.
we live pretty far away, will this be available to, I mean, will it be live or will it be like?
Yeah, if you call, we'll have a Zoom link for you to
Okay,
come in.
okay,
Yes,
'cause that'd be great.
absolutely. Yes, sir.
First of all, good morning.
Hey, how are you?
I'm fine, doctor.
Good.
My name is David Sotisk, and I just want to say a couple of things while I'm here. I'm here, my wife and I, I'm down from Memphis, Tennessee for a recurrent visit, my annual recurrent visit to Dr. Dattoli, whom I found in 2012. Prior to 2012, 2002, I was diagnosed with prostate cancer. Had my prostate cancer diagnosed. I mean, it was my gland was removed, which was a mistake, and the cancer came back twice. I was treated by 3 other doctors prior to seeing Dr. Dattoli, whom I found out about through a friend of mine who had seen Dr. Dattoli for his treatment. And so I got in the pipeline and came down to see Dr. Dattoli and had him treated in 2012. Had I not found Dr. Dattoli, I wouldn't be here right now. I'm sure I'd already been pushing daisies somewhere. And I just want to thank you, Dr. Dattoli, for what you've done for me and my
Thank you.
family.
Thank you, Mr. Jensen. Appreciate
I'm
it.
back every year. Happy to be here.